in English and Hindi. Some books have also been translated in regional languages as well as Indonesian Bhasha. 11 chapters in books he has written already, with 110 published articles in national and international journals. He is a member editorial board of Cardiology Today, member of the ethics committee of the governing council at Irvine College, Delhi University. With this short introduction, I'm sure I've spoken less of you, sir. I would request and I would ask you to take over the podium with and enlighten us with the topic resistant hypertension. Over to you, sir.
Thank you very much, Dr. Sanket, Mr. Manoj, the rest of the team from MacLeod's. And today I'm going to discuss an important issue that is resistant hypertension, and with focus on moxonidine. So what do I want to say, uh, let me just minimize. Yeah. Okay. So several clinical trials done in 70s and 80s, like heart trial, UKPDS, particularly in diabetic population, had shown that adequate pharmacological treatment of moderate or even milder degrees of hypertension reduces the cardiovascular morbidity and leads to better survival. In fact, it was shown that effective and long-term control of blood pressure to less than 140 and 90 millimeters of mercury reduces the stroke by nearly 40%, heart failure by more than 50%, and myocardial infarction by 25%. So there is a gradient between the benefits as in terms of stroke reduction versus heart failure and myocardial infarction particularly. And there are very many reasons for that. I'm not going to discuss all those reasons, but coronary artery disease, unlike stroke, is a more of a multifactorial disease as compared to stroke, which is driven mainly by the blood pressure levels. And that's why, and heart failure, of course, higher the blood pressure, higher is the risk of heart failure in a given patient when the blood pressure is not under control. So with this brief introduction, let me go forward and say just a very few words about the conventional hypertension treatment. And as we know, most of the guidelines, rather all the guidelines, they have given a change in the first line drug therapy, where beta blockers have been eliminated. And there are three classes of drugs: the RAS inhibitors, which means ACE inhibitor or ARBs, the calcium channel blockers, specifically mentioning the agents like amlodipine or similar agents, unlike diltiazem and verapamil, which are non-dihydropyridine, calcium channel blockers. And thirdly, thiazide and thiazide-like diuretics like chlorthalidone, hydrochlorothiazide, and indapamide. They are considered to be the first-line drug therapies for control of blood pressure. The first choice of antihypertensive medication also depends on the age and the race. Like, for example, in a person who is younger, it is preferable to start a RAS inhibitor like ACE inhibitor or ARB, and then go on to things like calcium channel blocker or thiazide-like diuretic. Whereas in people who are more than 55 years of age or 55, calcium channel blockers are the first agents to be used, and this may be followed by ACE inhibitor, ARBs, or thiazide-like diuretics according to these nice guidelines. And in the aging population, a calcium channel blocker, a thiazide-like diuretic like chlorthalidone or indapamide, and in some cases maybe hydrochlorothiazide also, but not so much nowadays, preferred so much. These are the agents, followed by ACE inhibitor or ARBs. And then, of course, it is not out of the way for me to say that many of these patients, particularly those who have got comorbidities, those who are aging, they require not one but two and maybe even three agents or even more agents for control of blood pressure. So resistant hypertension, what is resistant hypertension basically? Well, if a person is not getting control with three first-line agents, including a combination of ACE inhibitor or ARBs, calcium channel blocker, or thiazide-like diuretics, uh, and which is confirmed by elevated blood pressure with either ambulatory blood pressure monitoring or by home blood pressure monitoring, and the patient is adherent to the treatment that has been given, and the patient is receiving the adequate doses, the maximum tolerated doses, without unacceptable side effects. One could say that this patient who is not getting controlled is basically having a resistant hypertension. So in such cases, one could consider using second line agents. And what are these second line agents? Well, the second line agents could be an alpha blocker or a beta blocker if the potassium level is more than 4.5, and if the potassium level is less than 4.5, then one could consider starting low dose spironolactone. Uh, there are other agents also like moxonidine, hydrolazine. No, there are other agents. They are also considered to be a second line agents. Besides these, of course, the guidelines vary, in their usage as second line agents. So, without going into the BP targets, etc., let's say with the kind of blood pressure measurement that we have, practices in this country, the aim by and par is a clinical blood pressure of less than 140/90, and a home blood pressure or a daytime ambulatory blood pressure average of less than 135/85 millimeters of mercury. And of course, the nighttime blood pressure with ABPM should be less than 120/70. So many of the patients, they are not able to achieve this kind of blood pressure consistently over the long term, and the reasons are many. And the first thing that we need to rule out is basically the adherence to the treatment. You have to look into two things basically. One is whether the physician is adhering to the guidelines or not, whether the patient is actually being taking the medication that has been advised. So whether adequacy of treatment is there or not as per the guideline, that needs to be determined first. Uh, there are, a good number of patients who are not able to get the right kind of combination therapy with the right dosage because of physician related factors as well as the patient related factors, and the factors could be many, side effects of the drugs, cost issues, inability to come to terms that you have to take too many medications, presence of comorbidities which require not only 2 3 drugs but maybe 10 drugs, maybe sometimes patient with multiple problems, particularly the aging patient may require more than 15 20 drugs also. So it's very very difficult for a patient to actually keep up with so many complex medication regimes with so many medication. Cost is also a consideration. So once the adherence actually has been determined, and you know that the patient is taking what should be taking but not responding, then it's a case of resistant hypertension. So resistant to conventional medical therapy despite intake of 3 or more antihypertensive drugs with a blood pressure which is consistently more than 130/80 is something that needs to be taken as an evidence of resistant hypertension. And you have to consider number one, either second line therapy, or you have to investigate for a secondary cause which is preventing this inability of the patient to control his blood pressure. So it is not a small problem. Basically, almost 10 to 15% of the patients who are given antihypertensive drug therapy, they don't achieve the blood pressure, even with the best, kind of therapy, best possible therapy. I'm not talking of general population, but I'm talking of a clinical setting where you are giving the treatment, but you are not able to achieve the blood pressure, which is within the target limits. And this is particularly more common in people who are aging, those who are having left ventricular hypertrophy, those are who are from black race, those who have CKD, diabetes or obesity, and then of course those who have the secondary causes. So there is another term called refractory hypertension, where if a person does not get controlled with even 5 medications or more, then it is basically a refractory hypertension where you are giving not only the first line agents, including diuretic, but also a mineralocorticoid receptor antagonist like eplerenone or spironolactone. So, uh, in a general population, now I'm not talking about the clinical, setting where the everything is state of the art. The physician is delivering his, treatment. Patient is taking the treatment. Follow up is regular. But now let's talk about the general population and an American, survey, the NHA-NES, which is done periodically in America, showed that those participants who were being treated for hypertension, only 50% or 53% were controlled to a blood pressure of less than 140/90. And those with CKD, they had achieved, a blood pressure of less than 130/80 only in 37%, and only 25% of the diabetic participants had a blood pressure of less than 130 and 85 millimeters of mercury. And even in a clinical trial, setting like all-head trial, where things are basically, yeah, very good, very good. In all-head trial, after approximately 5 years of follow-up, where the drug administration is a very strict, protocol based and protocol driven, procedure. 27% of the patients were on three or more medications, which indicates that it's not easy to control the blood pressure even in clinical trial setting. So, what may be the causes for resistant hypertension? One is, of course, the definition. You have to define it properly, and it may be because of office or white coat hypertension that you need to confirm by doing home blood pressure monitoring, or better still by ambulatory blood pressure monitoring. Second is, of course, poor compliance with lifestyle measures or medical therapy. And here I may say that poor compliance with lifestyle measures is also something that needs to be considered very carefully, because drug treatment alone is not sufficient for control of blood pressure. The diet, the physical activity, the stress control, sleep, and overall, life stress, etc. These things do matter in control of blood pressure. Then, of course, uh, uh, pathophysiological basis like extracellular volume expansion, which has not been corrected by adequate dose of diuretic, like in CKD patients, inability to give diuretic of the loop diuretic variety, furosemide, or the other similar agents. Secondary hypertension, very important. And then ingestion of substances that can elevate the blood pressure, like drugs or food supplements like licorice. So these are some of the causes, and as I said, secondary hypertension is something that needs to be considered in certain situations where blood pressure is not getting controlled, or the blood pressure has actually increased acutely. Blood pressure has increased in people who are younger, like less than 30 years of age, and also at the other extreme of age, where blood pressure has been normal all your life, but it now starts rising after the age of 65. One needs to consider conditions like renal artery stenosis because of atherosclerosis, uh, exacerbation of previously controlled hypertension for no reason, uh, disproportionate target organ damage for the degree of hypertension, accelerated or malignant hypertension, uh, onset of diastolic hypertension, as I said, in older adults more than 65 years of age, and importantly, unprovoked or excessive hypokalemia. That may indicate that the patient may be having primary aldosteronism, which is found in 5 to 6% of the patients with hypertension if it is screened for in all cases in hypertension clinics. So you have to do screening test, proper screening test, and rule out the secondary hypertension. And these are some of the causes of secondary hypertension. I'm not going to go into the details for that, but renal parenchymal, renovascular disease, primary aldosteronism, drugs, and obstructive sleep apnea are some of the commonest causes for secondary hypertension. And these are some of the drugs and other substances with potential to induce or exacerbate elevated BP and hypertension, like non-steroidal anti-inflammatory agents, a very important cause. and with comorbidities like osteoarthritis or rheumatoid arthritis, intake of non-steroidal anti-inflammatory agents for pain control is a very, very common cause. Oral contraceptives not so common. Sympathomimetic agents, even nasal drops, cyclosporin, erythropoietin in CKD patients, VEGF inhibitors in patients who are receiving treatment for either cancer, or those who are receiving treatment for their diabetic retinopathy, alcohol, antidepressants, glucocorticoids, even mineralocorticoids. Now these are some of the agents which can cause an increase in blood pressure or even induce new onset hypertension. So one has to rule these out by asking the patient whether they are taking any other drug other than prescribed by you. Now coming on to the role of sympathetic overactivity in the pathogenesis of hypertension. Sympathetic overactivity may be a very important and central feature linking hypertension with other components of the metabolic syndrome. And there is a lot of evidence that sympathetic overactivity has got a strong link with hypertension in animal models, in humans, and if you really look at the pathophysiology of the hypertension in the initial stages, sympathetic activation is seen in a majority of cases in early phase of hypertension, and in fact it may precede blood pressure elevation in some patients. And of course, in a burnt out case of hypertension where hypertension has been there for a long time, this may not be so important because then it is a self-perpetuating phenomenon where hypertension could be because of irreversible changes in the vasculature in the form of microvascular changes, the fibrosis of the blood vessels, smaller blood vessels, etc. But sympathetic overactivity per se actually can increase the blood pressure and cause hypertension in a substantial number of patients, particularly those who are recent onset hypertension. Then the sympathetic overactivity is also responsible for rise in systolic blood pressure in young persons, where you find that the rise in the systolic blood pressure, diastolic blood pressure may be normal, and these patients have got a decrease in the aortic compliance, which is responsible for diastolic hypertension also in many cases. Uh, so there are several lines of inquiry which indicate that sympathetic activity is the cause rather than a consequence of blood pressure elevation, and it also needs to be addressed, and which is not as that strongly addressed to by ACE inhibitor, ARVs, calcium channel blockers, and the first line other first line agent, that is thiazide like diuretic. And that's why some of the younger patients particularly may require beta blocker, even though the guidelines do not mention it with clarity. The sympathetic overactivity is also associated with the obesity, where you find that there is an increase in the rate of sympathetic nerve discharge in the skeletal muscle. And if you do the experiments, you find that there is a correlation between the body mass index, body fat distribution, particularly the abdominal obesity, and urinary norepinephrine excretion. Then sympathetic overactivity has got a strong link with the insulin resistance and diabetes also, and that we all know. And we also know that cardiac autonomic dysfunction occurs in 30 to 50% patients with diabetes mellitus, and 40% of the obese patients without diabetes mellitus who are in any case prone to diabetes in the future. So sympathetic overactivity is a important component in several situations. uh, it is also implicated in renal disease. It may also be responsible for an exacerbation of left ventricular hypertrophy. And then, of course, we all know that in patients with congestive heart failure, there is an increase in the sympathetic activity. So, how do we go about evaluating and treating resistant hypertension? Well, you have to confirm this treatment resistance by ruling out situations like adherence to the treatment, non-adherence to the treatment, clinical blood pressure elevation but no elevation at home, etc., etc. And then you have to exclude, after excluding this pseudo resistance, if indicated, then you have to assess for secondary hypertension. And there one should actually be doing at least a screening for obstructive sleep apnea, primary aldosteronism or Cone syndrome by doing a serum potassium, and renal parenchymal disease and renal artery stenosis. But this is not required for all cases with hypertension. It is required only when you have a a patient with resistant hypertension which is not responding to the treatment. And then of course one has to assess for target organ damage, and if the target organ damage is out of proportion, one has to make an all-out effort to reduce the blood pressure by the use of second line drugs. So one of the objectives there may be reducing the sympathetic overactivity, because as you know, diabetes, obesity, CKD, all of these conditions which are associated with resistant hypertension are also associated with a increase in the sympathetic activity. So both non-pharmacological as well as pharmacological management of sympathetic overactivity should be addressed to, and that should be one of the primary therapeutic targets. Now coming on to the sympathetic overactivity, one has to discuss the role of the central sympathetic outflow. So, not talking about the peripheral sympathetic overactivity, which is the end result, it is the central sympathetic outflow, which may be an important factor in causation of high blood pressure due to sympathetic overactivity. As you know, the sympathetic nervous system activity is controlled and originates from hypothalamus, and that affects the brainstem, and stressful stimuli are transmitted from the sensory cortex to the hypothalamus, and finally to what is known as RVLSM, that is rostral ventrolateral medulla, a part of the brainstem. So RVLSM is the final common pathway for a number of descending influences of the sympathetic nervous activity in response to stimuli like stress, hypertension, exercise, and pain. So, briefly speaking, and to simplify this, stimuli like stress, hypertension, exercise, pain, etc., etc. These are transmitted from the sensory cortex to the hypothalamus, and that activates the rostral ventrolateral medulla, RVLSM, and that forms the basis for controlling the sympathetic activity by affecting the discharge, the neural discharge from the RVLSM. So selective blockade of the SNS outflow at RVLSM prevents the deleterious effects of sympathetic overactivity. Now there are two types of receptors there. One is the central alpha 2 adrenergic receptors, and second is the I1 receptors. Both of these, if they are activated, they increase the peripheral sympathetic outflow. So what needs to be done? Basically, what needs to be done is to inhibit the alpha 2 adrenergic receptors, and also inhibit the I1 receptors. Now, their effects are a little differential. Now, the effects are differential, and I will be discussing that in a few minutes. But coming on to the agents which reduce the activity of this RVLSM receptor, the alpha 2 agonist and the I1 agonist, you have two classes of agents. One is the first generation like clonidine and methyl dopa, and the newer ones include the moxonidine. So we will be talking about this, but let me say what happens with alpha 2 receptor stimulation, and what happens with the I1 receptor stimulation. So the first generation central sympatholytics like clonidine, they reduce the central sympathetic outflow primarily by stimulating the alpha 2 adrenergic receptors in the RVLSM in the medulla. So they are central alpha agonists. Okay, so they do reduce the blood pressure. There is no doubt about it. Clonidine has been there for a very long time. Methyl dopa has been there for a very long time, but their side effect is basically sedation and other side effects like dizziness, lightheadedness, drowsiness, dry mouth, constipation, and particularly with clonidine, rebound hypertension. And why does it happen? That happens because they are not selective. They also stimulate the alpha 2 receptors at the other regions like locus coeruleus and this may cause sedation and other side effects which I just mentioned. On the other hand, drugs like moxonidine, which selectively stimulate the I1 receptor in the RVLSM, they do reduce the central sympathetic outflow, but they don't cause sedation. And they are not so much associated with rebound hypertension. I'm sorry. So the benefit here with the second generation central sympathetic alpha agonist is basically that they are selective in their action. They reduce the central sympathetic outflow, but they don't cause sedation and other side effects. And the rebound hypertension is also not so much observed with them. So let's talk about moxonidine, which is basically an agent which reduces the central sympathetic outflow by acting on the RVLSM and selectively, they have selectively affect the I1 receptors rather than the alpha 2 receptors. So it's 200-fold more selective for I1 receptors than for alpha 2 receptors. So it does stimulate these receptors, which reduces the central sympathetic outflow going into the periphery, reducing the central sympathetic tone, causing a decrease in systemic vascular resistance and reduction in blood pressure. So we will be talking little more about moxonidine today because that is an agent which is an important progress over the older clonidine, which is still used nowadays, but more and more people are now being given moxonidine in preference to clonidine as a second line antihypertensive agent. So just how effective is moxonidine in reducing blood pressure? That is the first question. So in short-term trials like this 8-week trial, it was found that it is quite effective. In fact, looking at the systolic blood pressure compared to placebo, there was a reduction in systolic blood pressure in the study by almost 20 millimeters of mercury after 8 weeks of therapy, and diastolic blood pressure reduction of about 10 to 11 millimeters of mercury, which is quite substantial actually, but it is monotherapy. Okay, so it is not in resistant hypertension. Basically, it is showing the reduction in blood pressure in patients who were drug naive. Then coming on to the role of moxonidine in end-stage renal disease, you find that the sympathetic activity is definitely reduced with the use of moxonidine in patients with ESRD. The blood pressure control is also there, but as we know that in CKD patients, it is attenuated as compared to the unselected patients because drug treatment of hypertension in end-stage renal disease is anyway difficult. But certainly you find that this particular agent is effective, not so much, but certainly effective. And the important thing is that there are no serious side effects seen in patients with various GFR levels. And unlike clonidine, where patient with severe renal dysfunction, you should not be giving it. You may be giving it even in more advanced renal disease, but with reduced doses, particularly when eGFR is less than 30. Regarding the use of moxonidine in patients who are being given erythropoietin congeners, and this is an important point because erythropoietin and its congeners, they do increase the blood pressure in patients with renal disease, whereas it increases the hemoglobin, but at the same time increases sympathetic activity, leading on to hypertension, and even the risk of myocardial infarction is increased with the use of erythropoietin congeners. So in chronic renal failure patients, moxonidine in patients who are already getting an agent like aprosartan, you find that the sympathetic hyperactivity is attenuated, giving rise to a blood pressure reduction by 9 millimeters of mercury, microalbumin reduction by about 24%. So, adding on moxonidine to an agent which is already there in place, like aprosartan, which is an ARB in patient with CRF, you find that there is an additional reduction in blood pressure. Now, in patients with metabolic syndrome, once again, there are small trials like patients in this O.B.E.Z.I.T.A trial, 748 patients who had metabolic syndrome and poorly controlled hypertension. It's a 6 months trial basically. Majority of the patients they completed the study. No adverse effects were seen, and moxonidine, of course, was prescribed as an add-on treatment to the other antihypertensive agents. And the reason why it was added was the lack of efficacy of the present treatment. And the most frequent dose was zero point 0.4 milligram per day. And you find that the metabolic parameters all increase with the addition of moxonidine. So, blood pressure reduction, in addition to that, improvement in the metabolic profile, with moxonidine was something that was observed in these patients with uh, hypertension and metabolic syndrome. So you can consider moxonidine as something which is metabolically neutral, at least with an additive effect of positive effect on metabolic parameters modestly, and of course additional reduction in the blood pressure. Now regarding uh, this blood pressure control, better blood pressure control in the metabolic syndrome population. There is another study called MERCY. I will not go into the details of that, but it is of course a large study of more than 5,911 patients. It was a physician-based study in their clinic where moxonidine was given in a dose of zero point 0.2 to zero point 0.4 milligram once daily for 6 months, either as monotherapy or as an adjunct therapy to antihypertensive agent. And you find that adding moxonidine or just using moxonidine reduce blood pressure and improves the rate of blood pressure control in this group of patients. And the reduction in the blood pressure per se, it does reduce the cardiovascular risk. So it's an important agent where we have evidence of sympathetic overactivity. Now, once again, the efficacy of moxonidine in patients who are hypertensive but they are not controlled and they are obese also. Well, there was a marked reduction of blood pressure of 23 systolic and 12.9 millimeters of mercury diastolic over a period of 6 months with addition of moxonidine. And in addition to that, there was also a decrease in the peripheral insulin resistance and significant, improvement in the creatinine clearance reduction. So, moxonidine, well, suppression of obesity-related hypertension is once again related to the reduction in the sympathetic activity, overactivity. So, blunting of the sympathetic overactivity. Now, coming on to the elderly hypertensive where combination therapy is required, moxonidine once again has been found in a study to have significant daytime reduction of blood pressure by 15 by 7 millimeters of mercury during daytime with ambulatory blood pressure monitoring, and overall reduction of the same tune, that is just once again 14 by 7 millimeters of mercury. So moxonidine can be given as an added-on treatment in the elderly patients whose hypertension is poorly controlled despite treatment with the three or more agents. Uh, the added benefit of moxonidine as compared to clonidine is that it seems to be safe in renal failure patients, which is a common condition in elderly patients, and also it does not cause sedation, and it is metabolically neutral. Another study of moxonidine in combination. Well, this is a study with amlodipine, and you find that you could combine moxonidine along with amlodipine, and it offers the greater response to blood pressure reduction as compared to amlodipine alone. Similarly, it could be combined with an ACE inhibitor like enalapril, where you find that the uh, blood pressure reduction with moxonidine is same as enalapril, no difference. So one could even use them separately, but in most situations if you want to use you will be using this as a combination, and you may find additive benefit of a combination of enalapril along with moxonidine. So as a standalone therapy, similar reductions, combination, well, better reduction. Now, uh, it may be just a repetition of the same thing as with amlodipine, the comparing this with the nifedipine, long-acting nifedipine, which is not so commonly used, but still it is in use in some patients who are well controlled on the nifedipine long-acting. You find short-term studies in about 200 plus patients has shown that the reduction in the blood pressure with nifedipine and the moxonidine is nearly the same. Now, coming on to clonidine, as I said, the main benefit is basically the lack of side effects like sedation and other side effects. So the patient acceptability with moxonidine is much better as compared to clonidine, and the risk of rebound hypertension is also much lower as compared to the clonidine. So clonidine, though it has been agent which is considered to be a second line agent, particularly in patients who are having underlying renal dysfunction of moderate degree or mild degree. Uh, it is better to use moxonidine nowadays as compared to the the clonidine. Clonidine, the use is actually decreasing markedly because of the advent of moxonidine nowadays. This is a post-marketing study of about 4,005 patients in Germany, and you find that this PMS study showed a very significant reduction in the blood pressure of 24 systolic and 13 millimeter of mercury diastolic blood pressure. And the higher the baseline blood pressure, the greater was the reduction in the blood pressure. So this was a study done in patients with metabolic syndrome, and it was concluded that moxonidine effectively reduces BP in patients with metabolic syndrome, while it may also reduce the body weight in obese patients uh, to some extent. So there has been a lot of clinical, experience with moxonidine. Now it's not a new molecule anymore. It is surprising that it is not so commonly used, and the reason why it is not so commonly used still is possibly because of the fact that it is not a first-line agent according to the most guidelines. But certainly, given the fact that uh, sympathetic overactivity is a very common factor underlying the pathogenesis of hypertension and its perpetuation, I think it should be used more often in clinical practice, and particularly so when the first line agents are not being effective and the patient is already getting three agents. In fact, uh, just a thought has come to my mind that patients who have got sympathetic overactivity, we have a tendency to start beta blockers, but why not moxonidine as a second line agent instead of a beta blocker? Beta blockers have got a lot of metabolic side effects, and these metabolic side effects may actually increase the risk. Whereas moxonidine is metabolically sound, it reduces sympathetic overactivity, but not only sympathetic activity, it also has got some salutary effects on metabolic parameters like lipids and sugars. Even if that is not there in a given case, it is at least metabolically neutral, so it's better than beta blockers in patient with sympathetic overactivity. So the experience has been there, with clinical trial experience has been there for about 15 years. The clinical use in this country has been there for several years, and you find that the post-marketing surveillance study as well as clinical trials have shown that the side effects are very, very little as compared to older agents like clonidine. It may also have some pleiotropic benefits. Well, these benefits are plus minus. I will not deal in detail on that because these are not so well studied. So, but there are some pleiotropic benefits like metformin, uh, which has been found to be there in open label studies, but these studies are limited by the study design and limited number of patients. So we can safely skip that and go on to some in clinical trials. There have been two trials which have been done with Moxonidine in Indore in Mumbai, and This was an open, randomized comparative clinical trial to evaluate the efficacy of moxidine versus ramipril versus losartan. And you find that compared with losartan and ramipril, the reduction in the systolic blood pressure was more marked with moxidine. 16.5% reduction in systolic blood pressure with moxidine as compared to 10% reduction or 11% reduction with the ramipril and losartan both. So it may be more effective. In fact, the clinical studies have shown and the clinical trials have also shown that ramipril particularly does not reduce the blood pressure so much. It's not such an effective antihypertensive agent. The main benefit of ramipril is basically cardiovascular risk reduction. But mind you, reduction in the blood pressure per se is also going to reduce the cardiovascular risk. So, uh, if we go further, we will now be talking a few points regarding the nuts and bolts regarding the use of moxonidine. Well, food does not affect the absorption of moxonidine, so it can be taken irrespective of the food. Uh, it does cross the blood-brain barrier, but as I said, it is a selective I1 receptor agonist, so does not have the side effects because of its effects on other regions, like unlike clonidine, which affect the local cellulus and other things. Uh, 90% of the dose is excreted in the urine within 24 hours. So only 10 to 20% of the administered dose is metabolized. So this you have to keep in mind that uh, it is excreted in the urine. So very advanced renal failure, you have to be careful with the use of moxidine in the same dose. Well, it is rapidly effective, more rapidly effective, and the maximum antihypertensive effect is observed within 2 to 4 hours. And the effect persists for several hours after the drug disappears from the blood. So the plasma half-life may be just 1.85 hours, but the the biological half-life is much more, and you could give this in divided doses. Two divided doses are also fine, and you find that the effect is there for a longer period. But of course, the plasma half-life increases in renal insufficiency of advanced degree, and therefore the dose reduction is required. So the main indication for the present may be resistant hypertension associated with obesity, metabolic syndrome, diabetes, chronic renal disease of mild to moderate degrees, and also patients where you suspect that the patient has got sympathetic overactivity. uh, you could also use in mild to moderate essential hypertension, where you don't have, you could not be using the class, first line agents because of side effects, intolerance, or some other issue, but for the present, the main use of moxidine is basically in patients who do require multiple agents, and three agents are not enough, and also those patients where you expect that sympathetic overactivity is playing an important role in the pathogenesis of hypertension. Now, starting dose should be once a day, zero point 0.2 to zero point 0.3 milligram once daily, and you could use the incremental dose to zero point 0.2 to zero point 0.3 milligram twice a day. Unlike clonidine, which has to be given 3 times a day, at least for particular effect, uh, twice a day dose is enough. But remember, one single dose should not exceed zero point 0.4 milligram. It should not be used in pregnancy and lactation. And in elderly, you need to reduce the dose by about 50% because of the underlying age-related renal insufficiency. And in renal failure, where EGFR is 30 to 60, single dose should not exceed zero point 0.2, and no more than zero point 0.4 milligram per day should be given. Below 30, well, I will be a little wary of using moxidine in a, unless I'm using it in a very small dose, but I think it is better to avoid. And children, well, not to use before the age of 16 years. Uh, this is, highlighting the use of moxidine in patient with GFR of less than 30. Uh, Once daily dose could be used you can give a fair trial. As such, it does not cause deterioration in renal function, uh, uh, but you have to be careful that you give only a single dose per day and not to exceed zero point 0.3 milligram, and you have to watch the response because there is some issue regarding the excretion of moxonidine, even though it does not cause renal dysfunction, but overdosage issue may be there with moxonidine if the eGFR is really very low. And in ESRD, a patient with end-stage renal disease where eGFR is less than 15 or the patient is oliguric, it is better not to use this particular agent. Uh, when you want to use it with beta blockers, uh, the problem is that it can cause a excessive reduction in sympathetic activity, which is a driving force for several physiological functions. So beta blockers actually should be withdrawn in case you want to start moxonidine, but you should stop the beta blockers first. And uh, regarding uh, the stopping moxonidine in patients where you want to withdraw it, even though the risk of rebound hypertension is low, but still the action is like clonidine only. Uh, uh, this, it's a central, sympathetic activity is increased, giving rise to a decrease in the peripheral sympathetic outflow. So it is better to withdraw it rather gradually once again, even though the risk is low. Uh, Patients with the unstable coronary artery disease, it should be used with caution. Rather, it should not be used. It's not clear really for use in these patients. So it is basically for patients who have got chronic hypertension. Patient is stable clinically, and I've already talked about the use of moxonidine in patients with moderate renal impairment and in more advanced, uh, uh, renal dysfunction. Uh, I don't know history of new angioneurotic edema. It should be used with caution. I am not aware of any patient which has been reported to develop angioneurotic edema with moxidine, but the drug label says that if the patient has got history of angioneurotic edema, it should be used with caution, which means probably in practical terms should not be used. Just a second. So, moxidine, even though it is not a first-line agent, but it is an effective antihypertensive agent. Why it is not first line is because of the lack of outcome data in terms of cardiovascular benefits. That is one. It does improve the metabolic profile, or at least it is metabolically neutral. So it's a good agent to be used in patients with diabetes mellitus and hypertension, and those with impaired glucose tolerance and propensity to develop diabetes. So useful in patients with metabolic syndrome, as I said. The effect is prolonged, even though the half-life is short. It can be administered once daily, but in higher dosage, it should be preferably used twice daily so that the single dose is not exceeding zero point 0.4 milligram. It is much safer as compared to clonidine. It is well tolerated, and the drug interactions are minimal. And it is effective not only as a single agent, but also effective in combination therapy. So it can be safely used in combination with other first line agents. So that's it. I think I will stop sharing my presentation. And Dr. Sanket, uh, if we have any questions.
Uh, yes, sir. I think in the chat box on the right, where I can see a few questions, I already have been
Yeah,
positioned.
okay.
Just read them out for you, sir. The first question goes like, what is the prime reason for inclusion of moxonidine?
Yeah, I can read it actually.
Oh,
What
lovely. Okay, great. So,
primary reason for inclusion of Moxovas in resistant hypertension? It is only BP reduction, and your even expect a great MACE reduction. Well, see, for reduction in the cardiovascular events, we have other agents. We have agents like ACE inhibitor, we have got ARBs, we have got calcium channel blockers, we have got diuretics, but many cases blood pressure will not be controlled with these agents. So in that situation, you have to rely on other agents. Now, other agents, well, mineralocorticoid receptor antagonists are coming up in a big way because it has been observed that they are effective in the cardiovascular risk, particularly in patients with LV dysfunction or heart failure, but in other patients also who are at high cardiovascular risk. But remember that reduction does not mean only reduction in coronary artery disease. Reduction also means a effective reduction in blood pressure leading to a decrease in the risk of stroke, which is primarily uh, pressure defined, and also a reduction in the risk of renal disease, renal failure, also renal, the risk of hypertensive retinopathy, all of which are basically pressure defined. So uh, this is an addition for effective control of blood pressure without the expectation for a reduction in the risk for myocardial infarction. But other benefits are there because of the blood pressure reduction per se. Because you don't have too many alternatives left when once the blood pressure reduction is not there, which is required for patient with high risk, and therefore this is the welcome addition. The second question by Dr. Soni once again is, apart from CKD, which all classes of patient do you find high SNS involvement and when to suspect it for evaluation in patients? Well, one is CKD, of course. Second is resistant hypertension, where a lot many patients have got sympathetic overactivity. The third is basically young patient with hyperdynamic circulation. That is another. Patient with metabolic syndrome, where sympathetic overactivity plays a very important role. Patients with the diabetes mellitus, with central obesity, that is another. So all of these conditions are associated with sympathetic overactivity, where a central sympatholytic is something that may be used to the benefit of the patient. Beta blockers could also be used in some such situations, but beta blockers, first of all, they are not metabolically neutral. Secondly, they do not reduce the cardiovascular events, just like the second line agents which I have just mentioned. And of course, they are not tolerated by a lot many people because of their side effects per se, exacerbation of bronchial asthma, uh, increase in Raynaud phenomenon, cold extremities, and fatigue, vivid dreams, and anxiety. Sometimes the beta blockers can cause anxiety also. Now, regarding the third question, why should it not be added early as second line or third line? Well, first of all, let me say that the agents that are second line or third line, they are second line or third line because we don't have the cardiovascular data, outcome data available for them. The data that is available is basically based on the larger trials. So what we really need to know whether these agents will also reduce the cardiovascular outcomes or not. It is not that these may not reduce the cardiovascular outcomes, because we know from the beginning that reducing the systolic blood pressure by a certain amount will reduce the risk of stroke, the heart failure, as well as the myocardial infarction by this much percent. That is attributed only to blood pressure reduction. So the risk reduction is going to be there, but the important question that needs to be answered is whether this blood pressure reduction is only responsible for reduction in the cardiovascular risk, or there are some added benefits like the first line agents. So if it is proved in a larger clinical trial that these agents also reduce the risk of the cardiovascular events like the first line agent, then they will also be first line agents. But for that you need clinical trials, and we don't have the clinical trials. So that is why they are second or third line. But on a clinical basis, in day-to-day clinical practice, uh, you don't always go by guidelines, number one. Secondly, once you have exhausted the first line agents, or you're not able to use the first line agent for some reason, then it is time for you to consider second or third line. And amongst these, mineralocorticoid receptor antagonists, beta blockers, hydrazine, and moxonidine, all of these fare very well in treatment. You could use, and as I said in the beginning, that there are agents, there are uh, agents which are available in addition to the first line agents, is also because of the fact that there are certain patients who will not respond even to five agents. So you need to have agents like moxonidine in day-to-day clinical practice for patients who are not getting controlled on routine first line agents. They do reduce the cardiovascular events, but beyond their blood pressure reduction effects or not, that we really don't know. Okay.
Perfect, sir. I think that question must have come because in your session you mentioned that instead of beta blocker, I think you can go ahead with a centrally acting, which can reduce a lot of
Yeah.
the
Can
anxiety
it replace
related.
beta blockers as add-on in metabolic syndrome? You want to say, eh?
I think
METS means metabolic syndrome.
metabolic syndrome, probably, sir.
Well, it depends. If beta blockers cannot be used, it could be used as a replacement for beta blockers, because you do need to reduce the sympathetic overactivity, which is deleterious, right? Very right.
True.
So these are all the questions, or do you have any other question,
Sir, I have
Sanket?
a few questions with me. I would just like to ask you about the thing that you mentioned during the session, also about the anxiety component. So, as it is a centrally acting drug, and anxiety being a part of which can be a sign that we understand probably by looking at the pulse rate or a tachycardia. So, do you see that such patients who have high sympathetic outflow can be identified early for moxonidine and could help them?
Yes, but anxiety has got a multiple reasons. Anxiety is not only because of sympathetic overactivity.
Right.
So if there is a patient who has got baseline tachycardia or high normal pulse, a rise in systolic blood pressure, looks anxious, he or she has got tremors, excessive sweating is there. There is no thyroid problem. Now these are all clinical indicators that the patient has got sympathetic overactivity. And then of course you go into the psychological history of the patient. And if there is some evidence, you could try moxonidine in this patient.
Perfect, sir. Perfect. And sir, a last closing question for you, sir. So your approach for a patient who has reached you with uncontrolled BP with three optimally used class of drugs, how would you approach such a patient? You meeting him for the first time.
Okay. So first I will ascertain that the patient is taking the treatment that is being given to him. That is number one. Now suppose I find that the patient is taking the treatment, then I would like to check whether he is taking the right brands, because I'm skeptical about the generic brands. Nowadays, a lot of generic brands are there, uh, about which we are not aware that this is a generic brand of such and such medicine. And I'm not sure about the quality control. So uh, if they are taking some medicine which seems to be not so quality product, I may just like to tell the patient to take a branded product instead of generic product, whatever the government may say. But I as a physician, I have to inform the patient that this may or may not be effective. And this is very common with the patients who are coming from some government panels or some private companies where they have their own pharmacy, and they are dispensing medicines on their own, changing the medication from time to time, one brand once, second brand second time, and no brand third time, or switching over from an agent like say losartan to telmisartan, or vice versa. These things are very very common in Indian practice. Nobody has a respect for what a specialist will say. Then, of course, you have to see the right dose, whether they are taking the right dose or not. Are they taking the medicine at the right time or not? I also look into their lifestyle and ask them whether they are exercising. And majority of these patients actually are not exercising on a regular basis. They are gaining weight. They have some, reason or the other not to exercise. They have not exercised all their lives, but now they will blame lockdown on, lack of exercise, things like that. Then, of course, the salt intake. They talk about salt intake, but they are aware of added salt, but not the presence of salt in the cooked food. So I have to inform them. Uh, uh, Regarding the stress levels, a little psychological screening, two, three questions regarding, and 80% of the patients uh, will have some component of anxiety, particularly nowadays. Now, once all these things are there, then I look into their degree of hypertension, their age, their comorbidities, and if there is a reason for me to think about secondary hypertension, I do at least a serum electrolyte on them to rule out hypokalemia. That is one. I do a thyroid profile on them, and if there is any evidence suggestive of paroxysmal rise in blood pressure, like the patient says, I got a fluctuating blood pressure and I got episodes of very high blood pressure and tachycardia and palpitations at times. I also do a 24-hour urinary, catecholamines. Younger patients, I check the lower limb pulses for coarctation of aorta, things like that, so rule out secondary hypertension. And of course, renal function has to be reassessed. Uh, Renal artery Doppler, I do selectively, very selectively. Uh, uh, I don't like to do renal artery Doppler straight away on a patient who is not getting control. I first do a abdominal ultrasound, and if I find that the kidneys are absolutely normal, I don't go for renal artery stenosis unless there is a BROI. In the absence of BROI and normal kidney size, I don't really go in for renal artery stenosis screening by Doppler, because that's a cost investigation. So, so in some cases, I do investigate for secondary hypertension, and if the secondary hypertension is not there, then I go ahead with adding new drugs. The one of the agents that I prefer nowadays, in addition to the RAS inhibitor plus thyroid-like diuretic, there where my preference is for indapamide or chlorthalidone, not hydrochlorothiazide. I do, and of course, amlodipine is the one that is my choice for controlling the blood pressure with calcium channel blockers, not the newer calcium channel blockers like cilindipine and benadipine. I use them quite rarely because there is no outcome data with that. Then I go on to the antagonists like apelon or aldactone, the spironolactone. Uh, and the next one, of course, is moxonidine. So in case I can use a mineralocorticoid receptor antagonist, I use that. If I cannot, I use moxonidine. Hydrolazine, very, very uncommonly as such, because still recently it was not available as a single product. Now it is available, so I may be using it more often. The problem with hydrolazine is that it causes reflex tachycardia, and it may cause, side effects, immunological side effects, giving rise to lupus-like syndrome, rarely. So difficult to handle. So it is only third line agent for me.
Awesome, sir. I think this has given the attendees a great insight in understanding and treating patients who have reaching them with uncontrolled hypertension. With sir closing remarks, I would firstly thank you, sir, for the wonderful and enlightening session on the resistant hypertension and sharing your experience with us. I'm sure the listeners would have gained deep insights in managing a patient better using the learnings from your session. So we at McLeod's would like to honor your vast experience and your kind heart to share the same on such a platform for the benefit of all current and future listeners. As you know, sir,
Thank
this
you.
is a recorded session. It would be available on YouTube in future as well.
Oh, thank you.
Also, yes, sir. And also, I would like to thank and acknowledge a large set of audience today who is attending this session, sir. I take this opportunity to thank each and every participant attendee who has taken time out from his busy schedule and have respected our invitation to be the part of this scientific feast. Sir, I, as Dr. Sanket Niwale, representing medical team at McLeod Pharmaceuticals on behalf of marketing and sales team, I thank you for supporting us in this scientific endeavor. I wish you a great day ahead, sir. Thank you.
Thank you, Sanket and Manoj. Huh?
Thank you, sir.
Thank you.
Good
Sir.
night.
So I
Good
have
night, sir.
also
Good night.
concluded now.
Thank you so much, sir.
Thank you, Manoj.